So, may I have your attention, the esteemed faculties and delegates? I would like to take a few moments of your time to introduce myself and the distinguished faculty members of this session. A very good afternoon and a warm welcome to all the dignitaries present over here today. I am Rituparna from Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clarinet serves as the digital partner for this online event hosted by the National Neonatology Forum, Gujarat chapter. And the focus of today's session is Lessons from Expert Insight of Hypoxic Ischemic Encephalopathy. Well, now, without wasting any further minute, let's begin today's session, for which I would like to invite Dr. Kunal Ahiya sir, the Honorable Secretary of NNF Gujarat, to start the event today with his enlightening words and for the further coordination. So, over to you, sir. Please proceed with your talk.
Yeah. Thank you so much, Rituparna. So today we are continuing with our neonatal Pathshala series, which we conduct on every Wednesday between 3 to 4 p.m. So today we are having very esteemed faculty, Dr. Girdhar, with us, and he is be talking about a very important topic, that is hypoxic ischemic encephalopathy. So nowadays we are gradually, with improved obstetric care, we are day by day seeing less and less cases, but still those babies who have suffered due to some unfortunate event, we need to manage them well. So we are lucky to have Dr. Girdhar with us. Thank you so much, Dr. Girdhar, for accepting our invitation. For further proceedings, I will request Dr. Vishal, who is our project in charge for the neonatal Pathshala series. Over to you, Dr. Vishal.
Thank you, Kunal. Today's topic is regarding insights for hypoxic ischemic encephalopathy. And as Dr. Kunal already said regarding HI, that it is nowadays not very much common, but it is still a major cause for the mortality and morbidity if I talk about middle income country and low middle income country. And we know that the cooling is only therapy which is promising for the reducing mortality as well as morbidity in in case of the HI. And a few articles I think released before 2 3 years which create not controversy, but it is like put the question regarding the cooling therapy in not in middle and lower middle income country. And so we are going to discuss few things from that also in this session, I think. And also for that we do have a renowned faculty from India, Dr. Girdhar Seturaman, and he is currently working as a senior consultant in Neolife Children Hospital and a professor at Chetinath Hospital and Research Institute. If I talk about his major achievement, he already published more than 34 publications and also contributed lots of neonatology thing in the neonatology books, more than 6 in number. He is also examiner for DM as well as the fellowship in neonatology, an advisor and the co-developer of Neoped Indian Neonatal and the Pediatric Database software. He is also recognized trainer for the NIV, NRP, and facility-based newborn care organization, and joint organized secretary for South Neocon 2018 at Chennai. He was also executive board member for Tamil Nadu NNF 2015 to 2018. He already honored with the gold medal and also mentored neonatal trainee for award in state neocon and the research team CMAs. And he's also already invited more than 75 neonatology as well as pediatric conference in India and abroad. So I welcome Dr. Girdhar sir, and over to you, sir.
Yeah, thank you, Dr. Vishal, for that wonderful introduction. The outset, I would like to thank NNF Gujarat under the platform of Neonatal Pathshala for having taken up this great initiative to disseminate neonatal information across India and also globally. I think it's a wonderful platform because our students have also been listening to various speakers in this platform, and it's a very good source and repository of newborn information. So I thank the NNF Gujarat team, Dr. Kunal and Dr. Vishal, who are present here, and also to the president and the ex-president and the incoming president, and the advisors, our senior Dr. Somashekar and Dr. Ashish for also having given us this opportunity. So I'll just like to share my screen first. Just give me a minute. Yeah, is my screen visible?
Yes,
Yes,
it's
sir.
good. Yeah.
Yeah. Okay. So this will be the overview of my talk. So over the next 40 or 45 minutes, I'll be briefly touching upon these areas. Basically, I'll be talking briefly about the definition and the burden of neonatal asphyxia in India and across, and also how to identify the babies who have HIE and how to classify them. Then I'll be coming to the core part of my talk, that is the management and some future things which are on the horizon. So the definition itself is mostly self-explanatory. What is perinatal asphyxia? This terminology is something that has been interchangeably used with various other terminologies like birth asphyxia, your perinatal depression, or birth depression. All of them essentially mean the same. So we have a significant alteration in respiration, mainly oxygenation and ventilation, resulting in some sort of abrupt cessation of blood flow that happens during this perinatal period. That actually stands for perinatal asphyxia. But just to simplify matters, various societal bodies have given other definitions also. This is the WHO definition I've put up there. Very simple definition, which can be followed in various settings. A failure to initiate and sustain breathing at birth. As you can see, very simple definition. NNF went a step ahead and slightly expanded the definition to include one assessment of Apgar score, which is most likely to be available at most births. So the baby is supposed to have moderate asphyxia if it is having slow gasping breathing, or an Apgar score of 4 to 6 at 1 minute, or if it's going to have severe asphyxia if the baby is not breathing and Apgar goes even lesser, less than 4 at 1 minute of age. As you can see here, I mean, none of these definitions are actually, useful for current day management of perinatal asphyxia. And about that, I'll talk to that in the subsequent slides. So this is the epidemiology of perinatal asphyxia. And as you can see, we are a developing country. So our country is a very unique place because as in other LMICs, we are catering to diverse neonatal setups with various degrees of expertise and also various availability of personnel and resources. So because of this reason, and also because of a country having very high births with not very standardized antenatal care being applied in all settings, and some of these deliveries being attended by non-skilled assistants also, some home deliveries also, the burden of perinatal hypoxia or perinatal asphyxia is supposed to be higher in low and middle income countries, especially India. So this is some data from a recent systematic review. And as you can see, in HICs, the incidence is 2 to 3 per thousand live births, whereas in LMICs, there is a broad range, about 1.5 to 20.3 per thousand live births. This is from 45 studies with sample size of 3,307 infants. And more importantly, a lot of these babies actually die. They die either in the hospital itself or they die after going home. The case fatality rate is as high as 19.2%. And not only do they die, there is a lot of long-term morbidity also. You can see here the combined outcome of death and long-term disability at 1 to 3.5 years. It's almost doubled from 19%, it goes up to 45%. And mind you, this not only increases decreases the quality of care for these babies, but also increases the financial constraints on the family, because these families face a loss of burden in the long-term care of these patients with severe disabilities. So this is a very important topic about which we have to know and manage adequately. So these are the clinical features of perinatal asphyxia, and the most common clinical feature is something called HIE, which is going to be the crux of my talk. I'll not be talking on this now. I'll talk about this in the later slides. But you understand that a perinatal hypoxic or a renal asphyxial event will not only involve the brain, it involves other organs in the body also. Most important of these are the lung and the cardiac concerns which the baby could have. Cardiac concerns, mainly myocardial dysfunction and pulmonary hypertension. Lung concerns, that could be an acute lung injury with secondary surfactant deficiency. So all this could require ventilation and also inotropic support for improving the contractility of the heart. Acute kidney injury, basically the tubular necrosis, can also be a manifestation of perinatal hypoxia. Liver dysfunction is also quite common, and you know that liver dysfunction could have various ramifications because the drugs which we use to treat your perinatal hypoxia are all metabolized in the liver. So we need to be careful with a lot of these drugs to avoid some side effects. Gut injury could be there. This is more common, especially in preterm infants with the perinatal hypoxia. And not only feed intolerance, NEC also is very common in this scenario. And people have attributed this gut injury to the redistribution of blood flow away from the slackening circulation towards the vital organs. And metabolic derangements are also very common. And very common among the metabolic derangements are going to be your hypo and hyperglycemia, and not to mention hypocalcemia and some hypomagnesemia. And lastly, bone marrow is also one site which could get affected with perinatal asphyxia, and thrombocytopenia, your deranged coagulation parameters because of decreased production by the liver, and also increased consumption as we see in disseminated intravascular coagulation, all could be manifestations of perinatal hypoxia. So let's come to the core of my talk, that is HIE. HIE stands for hypoxic ischemic encephalopathy. So this section will be, I'll be dealing mainly on the definition, the clinical diagnosis, and the staging of HIE. So when it comes to definition of HIE, the name is more or less, it is self-explanatory, but we have to understand that there are two terminologies which we need to use at birth. Right at birth, we are mainly talking about this particular terminology here, that is neonatal encephalopathy. By encephalopathy, we mean that there is some disturbance in neurological function, which could be manifesting as an abnormal level of consciousness or some seizures with an association with some difficulty in maintaining respiration or depression in tone and reflexes. All these could be there. This could be the broad terminology called neonatal encephalopathy. But you have to know that encephalopathy could be because of multiple reasons. These may be generally get admitted and evaluated. So other things of encephalopathy, causes of encephalopathy need to be ruled out by your antenatal history or a family history, and any other mods even could be contributing to encephalopathy, or it could be because of genetic reasons, metabolic reasons, placental reasons, and some corroborative evidence from the MRI brain. And finally, we arrive at the final diagnosis. So now neonatal encephalopathy has many subsets, and one of the subsets is only going to be your neonatal encephalopathy HIE, and a lot of other subsets like sepsis, genetic, metabolic, stroke, syndromic, and unclear etiology. This is very important because not only does it have an implication when it counsel the family regarding the cause for encephalopathy the baby is having, it could have some legal implications also, which I will talk about in the last few slides. So just to make matters clear, the term encephalopathy because of hypoxia ischemia needs to be attributed only when we have certain things that are actually linking that significant intrapartum or peripartum event with the encephalopathy. And by this, I mean basically the newborn signs, that is a low upgar, a low umbilical artery pH, or a higher base deficit. Some neuroimaging, it has been done in the immediate newborn period, which is consistent with hypoxia and ischemia, and also some multi-organ dysfunction, which could be there. Multi-organ, I mean that two or more organs getting involved here. These are the newborn signs that are consistent with an acute, intrapartum or a peripartum event, which could be linked with HIE. Not only these, always probe your history. Ask the obstetricians whether there was an antenatal hypoxic or ischemic event like a ruptured uterus and very severe abruption which has happened, a cord prolapse, or a mother had any acute cardiac arrest or something else she has had, a fluid embolism or something, which could have resulted in the baby getting compromised in utero itself. And other corroborative evidence is going to be your abnormal fetal heart rate tracing by the CTG, especially a category 3 trace. And also, this is likely to be corroborated with the initial MRI patterns, again, which I will talk in the subsequent slides. And importantly, there could be no evidence of other factors which could be there, like scans earlier should have been normal. All these things are there. Then we could say that that acute event which happened in the peripartum or the intrapartum event is what has contributed to the hypoxic ischemic encephalopathy. And in our country, we see that a lot of us get back cases on follow-up, which have been managed elsewhere with some in different settings, which coming to us with some encephalopathy at some point of time, be it 3 months, 6 months, 9 months, or even a year, and they want to know why the baby is not having developmental delay or having not developmentally normal. At that point, one of the things that we order is an MRI, and we have the MRI pattern that is corroborative, and also there is some amount of spasticity consistent with spastic quadriplegia or a dyskinetic cerebral palsy. Then also we could say that it is actually the acute intrapartum or the peripartum event which is actually contributed to HIV. So let's look into the classification. So classification is something which you have read as undergrads period during a pediatrics, also during a MD pediatrics, and also during the DM time. So since a lot of fellows will be there on this platform listening to this talk, so we should, I mean, we all know about the Sarnath staging, which was given by in way back in the 1970s and modified by Sarnath themselves a little bit later. So from initial 14 elements being there, the first staging, they narrowed it down to 5 elements later. And then came the Thomson staging in the late 1990s. And I'll talk about the Thomson staging a bit later. And then what we're using now is the NICST staging system for thing, which is the modification of the modified Sarnath staging, and which has basically 6 categories or 9 elements there. Again, about which how to use that NICST staging, I'll talk between the subsequent slides. And some other staging systems have also been proposed. This is the Ibero-American staging system, which was developed in the US. And the advantage of using this system is this could also help us to grade as mild HIV. And we know that mild HIV is not always innocuous, which could have an implication in long-term prognosis. So this is more, accurately described by that classification by the Saiban Ibero-American classifications. So this is the golden rules for assessing encephalopathy. This is what we're doing right now in 2025. As I told you, the NICST modified Sarnath and Starnath staging is what is commonly being used. And one other, commonly used staging system is the Thomson score. But right now, most of the experts seem to be discouraging the use of the Thomson scores. Reason being, Thomson score was devised for low middle income countries and was extensively studied in African countries. But if you see the components of the Thomson score, there are some very subjective components like seizure analysis, the frequency of seizures, and which could be because you know that most of the seizures are subclinical and it's only EEG based. And second thing is some very dubious parameters are also there in the Thomson score, like your assessment of your anterior fontanelle. So all these things, the use of this is actually being questioned. But Thomson score still is a very attractive score. People who are using Thomson score watch for it. But right now, experts agree that the modified Sarnath and Sarnath NICST scoring system is the one that should be used. And in this scoring system, it is not mandatory that you should have an EEG, but EEG, I'll talk a bit about it a bit later. And in this NICST scoring system, we have two phases. Basically, we have an observation phase and a manipulation phase. It's only self-explanatory. Why the exact chronology about which I'll be talking about this NICST system It is not the order will be different from what it is there in your textbooks. Basically, because we bring the observation criteria earlier, and then the manipulation criteria, basically not to stress out the child and elicit the pain, because that could be slightly biasing our, observations. And lastly is, when you have multiple categories in a scoring system, there is likely to be a lot of subjective errors also. But when you have some difficulty in assigning a particular HIE stage as per this scoring system, the final thing that makes a diagnosis is the level of consciousness, about which I'll be talking into the subsequent slide. So this is the modified SARNAT and STARNAT NICHT scoring system. So first I'll be talking about the observational things. So first, when we see a baby with encephalopathy and decide, whether this baby is having amount graded, we look at the spontaneous activity. We know that the normal newborn is born at term will be actively moving its limbs, having good variability of the movements. And so this will be mildly reduced when the baby is having mild encephalopathy, especially the variability. But if you are having moderate or severe, this active movements are markedly reduced and the baby appears to be more or less sleepy. And if it's going to be severe, there is no activity. So it's very simple to look at the spontaneous activity and get it as mild, moderate, or severe. The second thing is a posture. So again, this also is very clear that a newborn baby should be having a universally flexed posture. If there is less of flexion, especially in the hips, and there is some flexion at the knees and your elbows, and then the baby could be having mild encephalopathy. If it is moderate, the flexion at the hips is totally gone. The hips and your, it's not, it's almost in a frog-leg position. But if you look at the distal extremities, especially the wrist and the fingers, there will be strong flexion of the wrist and there will be adduction of the thumb across the fist. These things will tell us that the baby is having moderate encephalopathy. And if it's going to be severe, we could expect a baby with decerebration, especially the hand, neck at the back are in the arch positions. And the elbows and wrists are all extended. The wrists are pronated and hips are adducted. So this posture is very classical, as you can see in this picture. And this says that the posture is fitting in with a diagnosis of severe encephalopathy. Next, about the vitals. Normal baby vital 100 to 160. The baby is having tachycardia, it's in mild. The baby is having bradycardia, but some increases are there, but only occasional to more than 120, it is moderate. If the heart rate is very variable, occasionally it is bradycardic, occasionally it comes back to normal, it's not sustainedly going up, then it is in severe encephalopathic stage. Again, the respiration in the vitals, if the respiration is regular, it is normal. Some amount of periodic breathing is there, but there is no desats, it's mild. If it's going to be periodic breathing with desats requiring some oxygen support or NIV support, it's going to be moderate. And any baby who gets intubated, so for apneas, or even it could be for some other reason, even it's breathing, but it's on invasive mechanical ventilation, then we score it as severe encephalopathy. So these are the manipulation phases where we need to touch the baby, manipulate the baby, and then grade the baby. So the first is level of consciousness. As I told you earlier itself, this is one category which is actually having the highest predictive value for categorization. So if this becomes abnormal, we give more and more weightage to this. A baby who's having mild encephalopathy, if there is some external stimuli, like the moment you touch the baby, it goes in for exaggerated morose, it could go in for excessive jitteriness. And this characteristic is very classical of a mild encephalopathy. If there is a response to the external stimulus but is delayed and it is also sometimes incomplete, then it could be moderate encephalopathy. And if there is no response or it's very unresponsive to external stimuli, then it could be fitting in with severe encephalopathy. The next factor is tone. As I told you, a newborn has a strong flexor tone in all the limbs. There is a slight increase in tone. It is mild. There could be either hypotonia or hypertonia in moderate, or the baby is flaccid, which is a very severe form of hypotonia, or it is very rigid, otherwise very severe form of hypertonia, then it could go in for severe. So last thing we have to assess is the reflexes. Reflexes is we talk about the suck reflex where we place the gloved finger or a clean finger into the baby's mouth. A normal baby we should be able to free the continuous stripping which happens, and at least 7 strippings should be documented. The strippings are less, but still there it is in the mild category. Strippings are almost not there, or the baby is occasionally biting the thing, but there's no stripping at all. Then it is moderate, and nothing is there, no suck at all, it becomes severe. Moros also, if it is a partial response with a low threshold, it becomes mild. If it is again a partial response, but it stays partial, it is moderate, and its Moros is absent, it's going to be severe. And the pupils are the last parameter to be examined. We know that the normal pupillary diameter is 1.5 to 2.5 millimeter, and anything more than 3.5 is mydriasis. And if it is mydriatic, it's going to be a mild encephalopathy. If it is constricted, that is less than 1.5, it could be our meiosis is there, then it is moderate encephalopathy, or there is Q deviation or unresponsive, or some dilatation non-reactive to light, then it becomes severe encephalopathy. So, I mean, this is a very busy slide. I know that just looking at it and hearing me will not make you actually very expert. I mean, very, conversant and with this sort of doing this examination. But this is a very important part of when examining the baby, because our criteria which we choose to actually start our treatment all depends on the categorization of encephalopathy as either moderate or severe, because those are the babies which will be requiring further care. So, and this is another refinement. So there are as I told you, 3 or more categories are being involved. Then it is going to be based on which is the category. If it's going to be severe category, it is severe. It's going to be moderate, it's going to be moderate. But it could happen that out of 6, 3 are there in moderate and 3 in severe. If that is the case, means we assign as per the level of consciousness. That will actually give us which category the baby has to go to. The worst level of consciousness will be the category of encephalopathy. Also, it could happen that only 2 or more less areas will be involved here. That is the case, always look at the seizures. If seizures are there, then automatically it becomes moderate. Even if we have a mild baby with less than 2 features, or more than, both features are in the mild category, the baby has been found to have seizures, then automatically becomes moderate. Only if no seizures are there, it stays in that particular category. So seizures is one thing that has undergone a lot of changes, especially after that ILAE new classification which came in 2020. And this is about the etiology of seizures. As you can see from this diagram, that HIE constitutes the bulk of newborn seizures. And this is the ILAE framework for classification of seizures. And the more important thing here is most of these seizures are electrographic seizures. Only some of them are electroclinical seizures, but these are the seizures which is actually visible to the naked eye. So we have to be more well versed with picking up these electroclinical seizures or the clinical seizures. Electrographic, of course, you can pick it up with your EEG or an AEG. So when it comes to clinical seizures or electroclinical seizures, these are the ones which actually matter. So the recent classification is the as motor, non-motor, sequential, unclassified. There are various categories in motors like automatisms, clonic, tonic, myoclonic, and spasms. And your non-motor, mainly the autonomical and some alteration in behavior. And it's going to be a mixed one, it's going to be sequential, or it could be an unclassified one. So let's look at some of these seizures, which could be a manifestation of HIE. So the earlier terminology which we gave for this seizure variant is called motor subtle seizures. Right now it is called motor automatisms. So these are the automatisms which we could come across. Basically, baby having orobuccal lingual movements. This is a baby which is having some nystagmatoid eye movements, but there is constant deviation of the eye to one side. And if you see this baby here, that's not only posturing, there is some roving motions and pedaling movements. So these are the all different types of motor automatisms which we see. And why I put up these 3 is, except for these 3, most of the other motor automatisms which could happen don't generally have a EEG correlate. These 3, there is EEG correlation is likely to be there, and these are likely to be more. The diagnosis of patient should be more in this 3 variants. So this is another form of seizure called multifocal clonic seizures, where we have a fast and we see some jerks happening in various areas. We have a fast and a slow component. It's going to be multifocal clonic. Again, very common in HIE. So another one which is not that common in HIE but still could be there is something called the tonic predominant seizures. So we can see these babies here. So we have a baby who's arching here. There are some rowing movements, but these could be automatisms. But this arching is a tonic spasm. So this tonic arch, that is because of some increased, sustained increase in the tone of the trunk or the limbs, which could happen, is actually a tonic predominant seizures. And mind you, even though this form of seizures can develop in HIE, if it is the only manifestation and there is no corroborative birth history, we should always think in terms of your epileptic syndromes in the newborn period, like your KCNQ2, developmental and epileptic encephalopathies and all. So these are more seizures. These are your myoclonic jerks. These are very, rapid jerks which happens. And the important thing is they have a predilection for the flexor group of muscles. So they could also be focal or generalized. And again, these are the ones which are frequently non-epileptic because jitteriness also could be like this. Your sleep myoclonus also could be like this. So without a EEG correlate, generally we don't treat these sort of myoclonic seizures. And this is the last seizure video where you can see that baby who's obviously having some derangement in neurological function, suddenly going in for a flexion or a flexor spasm here. So these are the infantile spasms, and this is called epileptic spasms. And this is very characteristic of HIE because this can occur if there is HIE. Also, it occurs in some inborn errors of metabolism and other developmental epileptic syndromes also. But if it is there, and if your background history is there and this is also there, then this baby is most likely to have seizures. So what about seizures? As I told you, seizures presence itself, it did not even have the neuro exam. It will tell you that the baby is having moderate encephalopathy. And there is a neuro exam and you have a seizure, you go by the neuro exam. There is a neuro exam, no neuro exam have a seizure, then we code it as a moderate encephalopathy. So let's come to the last part of the talk, that is the how to manage these babies. So once we diagnose a baby with neonatal encephalopathy, and we have some history of an newborn signs and also the intrapartum and the peripartum history telling us that this could be HIE. Our management is more or less going to be the same. So these are the in the NRP when it comes to delivery room management, we follow the standard NRP guidelines. So some recent work which has come up in 2023 years, we know that NRP recommends against delayed cord clamping in babies who are born non-vigorous at birth. But in this particular subgroup, term infants who are non-vigorous at birth, your cord milking could be very useful. And cord milking, this is the study from Kataria et al. Who had used the intact umbilical cord milking and compared it against early cord clamping, which is the current NRP recommendation, and looked at the various outcomes. Very importantly, in this particular study called the MINVI trial, they found that the incidence of moderate to severe HIV was significantly lower in the milked group. Also, the need for therapeutic hypothermia was lowered in this group. So if you have a baby who is born depressed at birth, at least do cord milking. If you cannot do delayed cord clamping, that is a message from this slide. And once the baby comes to the NICU, I think that the transit from your delivery room or from your outbound unit to the NICU is also very important. So at the NICU, we should ensure that the transit is not compromised and the admission temperatures are between 36.5 to 37.5. Because if it's going to be low or it's going to be high, again, we could land up with more brain injury. And in the NIC, we document the main vitals and we maintain the BP between 40 and 60, just like we do for any other term infant, the CRP in the normal range, lactate less than 4, and avoid metabolic acidosis. A pH should be ideally more than 7.2, base deficit of up to -4 is acceptable. Most of these babies are actually on the ventilator. So a blood gas becomes more or less mandatory in this situation. A PO2 between 60 and 80 is very important here, and we have to avoid both hypocapnia and hypoxemia and hyperoxemia because both could be deleterious to the baby's brain. And this corresponds to a saturation between 90 and 94. The CO2 also should be in the tight range between 35 and 45 because hypocarbia is even worse here than hypercarbia because if it's going to be hypocarbia, we could land up with cerebral vasoconstriction and worsening of the neurological injury. And again, glucose also should be in the tight range of 70 to 110 and avoiding hyperglycemia is very important here. Calcium should be in the normal range. And remember that these babies commonly have associated lung injuries and also pulmonary hypertension with some cardiogenic dysfunction. So early HFV nitric oxide should be considered in these babies when it comes to management of the hypoxemic respiratory failure. So seizure, babies likely to have in the first few hours of life and anticipate seizures in the first even 24 to 48 hours of life. And after the recent neo-lev trial, once your seizures are not controlled and you have taken care of your metabolic and sugar rearrangements, then the first line AED of choice is going to be a phenobarbital and if it's not controlled even with that and you have escalated the dosage up to 30 to 40 milligram per kg, the second line could be either of phospheniton or levetiracetam. We don't have we don't have studies to comparing these two because we have only one study which compared levetiracetam against phenobarbital as a first line treatment which said that phenobarbital was better. But units can interchangeably use depending upon their expertise and experience with these drugs. And if it's going to be ongoing seizures, again, we go for midazolam and add-ons can be added. So this is a seizure algorithm. I don't want to go in too much into this. So I'll come to management. We have talked so far, talked about the management of HIE in terms of what we do in the delivery room in the NICU and how do we treat seizures. Now we can look at how to protect the brain. This will be including some physiology slides also because brain injury is something that happens. Some of the times it's inevitable, but there are some windows of opportunity which could crop up in the first few hours of life. So this is an injury which has happened, be it a intrapartum event or a peripartum event. Any injury is followed by a primary energy failure. So this primary energy failure is your depletion of your ATP, which results in necrotic cell death. So this cell death could become permanent, but usually this primary energy failure becomes manifest in the first 30 minutes of life. So after that, in most scenarios, once that insult has gone, there is a reperfusion phase. So during this reperfusion phase, the babies transiently recover. During this reperfusion phase, the brain enters something known as the latent period. And after this latent period, there's a secondary energy failure where you have a secondary mitochondrial failure and more ATP depletion. And a lot of exototoxic mediators also play a role in causing the secondary energy failure. But you have to remember that between the primary energy failure, which becomes manifest by 30 minutes of life, and your secondary energy failure, which starts at nearly 6 hours and extends to up to 72 hours, there is a therapeutic window here, a window of around 6 hours or 5.5 hours, where some intervention could actually stop your brain from progressing to, from your primary energy failure to secondary energy failure. And this is the therapeutic window which we are making use of at this point of time. So therapeutic hypothermia is something that is a standard of care for management of HIE. Controversies, I'll be talking it in the subsequent slides. So this is how we do therapeutic hypothermia. We cool to a particular range by the first 30 minutes of life. Then that is the induction phase. Then we enter the maintenance phase where we maintain it at between 33.5 to 34 point, I mean, up to 34 in this maintenance phase, which goes on up to 72 hours. Then we remount and bring the baby to the normal temperature. So why should we cool these babies? So initial animal studies, especially the studies done in lambs, clearly showed that cooling in the first 6 hours of life, that is how that 6-hour criteria came, resulted in neuroprotection. And since then, a lot of different studies have come both from high-income countries and low middle-income countries. And the Cochrane review, which was last updated in 2013, which included 11 trials, showed that therapeutic hypothermia resulted in reduced reduction in the risk of death or major disability at 18 to 24 months, with the number needed to treat being 7. And the number needed to treat was also pretty good for the standalone features like reduction in mortality or prevention of disability, which is about 8. So this is a very good treatment, and even the NRP recommendation is that such that it is a standard of care for management of babies who presented with moderate or severe encephalopathy. So this is the criteria which we usually use to cool. A baby should be at the PMA of 36 weeks and above. And not only the PMA, we don't cool very small babies. The lower cutoff is, as per those criteria, was 2 kilos. But we in India, where we have a lot of SGA infants, we choose babies also who are more than 1.8 kilos if they are going to be more than equal to 36 weeks. Then we look at for either of these criteria, that is evidence of fetal distress or neonatal distress. By fetal distress, we mean that a cot pH is going to be less than 7, and we can even accept 7.1 in the first 1 hour of life, or a base temperature is going to be more than 16 or more than 12 in the first 1 hour of life. So since a lot of us don't have access to your blood gas analysis, so at APGAR, which is almost universally given, even though in retrospect becomes a very important tool here, your 10-minute APGAR is the one that has been commonly recognized to and added to the criteria for scoring. So 10-minute APGAR is going to be less than or equal to 5. That becomes an evidence for neonatal distress. But in India, since people generally don't give 10-minute APGARs, and a lot of babies are born outborn, and we receive the babies and start managing them, a 5-minute APGAR can also be chosen. And last thing is, a lot of times even APGAR scores are not there. So how do we then find out whether the baby there has been a significant fetal distress? So this could be because baby could be brought in a state where the baby requires assisted ventilation. And if there is history saying that the baby required assisted ventilation at birth because of not having cried, and this went on at least for next 10 minutes, then this all could be surrogate evidence that this baby could have had a significant hypoxic insult. And last three, I told you about your neuro exam. That is a primary method of determining the encephalopathy and categorizing the encephalopathy. And nowadays, since EEG is available even in a lot of units in India, and AEG is also freely available, if your unit has an option to perform this, go for these things, because these are all very important. And as I told you, in India, the population is very unique because we are likely to see a lot of babies who are born elsewhere in various settings getting referred to our hospital for not having cried at birth. So where we don't have access to the cot or even the 1 hour blood gas. So ABGAR scores become important here, but that is also a lot of times fallacious. So requirement for assisted ventilation or 10 minutes of life becomes more important here. So what about the criteria? We should cool babies only at 36 weeks and above, or can we cool babies who are slightly smaller? We don't cool babies who are less than 32 weeks. Some of the trials previously included babies up to 35 weeks also, but there was a very recent trial published in JAMA Pediatrics, which around a week back, which actually looked at therapeutic hypothermia for the baby who are born late preterms, especially we were born moderate preterms in the early late preterm period, the ones between 33 and 35 weeks of gestation, where the authors noted that even though the combined outcome was not different between the normothermic group and the hypothermic group, in the hypothermic group they had more deaths. So right now, cooling babies who at 35 weeks after this criteria will be a bit difficult because of findings from this trial. So when to start cooling, how much and how long to cool? So when to start, I told you earlier itself, we have to start in the first 6 hours of life. This is basically based on animal studies. And how much to cool is the temperature, tend to maintain the temperature between at 33.5 plus or minus 0.2 degrees centigrade. But trials have actually looked at deeper cooling also, cooling at 32 degrees versus this one. And they found that deeper cooling resulted in higher mortality. That is 14% in the deeper cool group. So at this point of time, the temperature range should be between 33 and 34. and ideally at 33.5 plus or minus 0.2. Then how long to cool? People have looked at cooling for 72 hours versus 120 hours, and they found that cooling for 120 hours offered no benefit. Some of the short-term morbidities were higher in the 120-hour cool group. So right now, the duration of cooling is going to stay at 72 hours. And this is a very important thing because recruiting babies who come after 6 hours, that is between 6 and 24 hours, having suffered a parental hypoxic event. So this was a trial which was published in 2017 from by Lactuk et al. From the NICHT network, which looked at this recruiting these babies and cooling them. I mean, they found some benefit. There was a marginal benefit of cooling in these babies, but it was very marginal, only a 2% benefit. Just for getting a 2% benefit, the cool babies who are coming to you between 6 and 24 hours. And we know the problems with cooling, especially in a country like ours, where the ways we cool and how we monitor these babies all could be very diverse. So we don't generally recruit babies who are more to be born more than 6 hours. So the very important question is whether does cooling work in low and middle income countries? And this was after, I mean, earlier trials showed that from India, from various parts, especially in South India, showed that cooling does work. But all this changed after this publication from Imperial Group in 2021, which was a randomized control trial, which was conducted in centers in India, Sri Lanka, and Bangladesh, predominantly in India, where they found that cooling babies with the same NICHT criteria with some modifications actually resulted in more deaths either before discharge from the NICU or even on follow-up, deaths were more in these babies. So because deaths were more in these babies, I mean, the authors suggested that we should not cool babies, especially in low middle income countries. But the conclusions of the authors were being widely contested in various deliberations and replies to the authors. So we don't have to go into the nitty-gritties of this one. But at this point of time, there is still controversial whether we have to cool in low middle income countries where settings could be diverse. So to actually clarify matters a little bit more, I mean, our National Neonatology Forum formed an expert group and they analyzed all the data from the low middle income countries and high middle income countries. And they tried to pick up some factors which could actually influence, I mean, mortality in hospital in these babies who are getting cooled. So a very important factor here is whether the baby is born extramural or whether it's going to be inborn baby and outborn baby. If you are taking only the inborn baby, then the cooling becomes very significant. But we're recruiting outborn babies where death before discharge from the hospital actually becomes slightly more. And so the combined outcomes combined outcome is not significant. So choose, I mean, if you have an intramural unit, it's all the more, I mean, you can go ahead and start cooling. But babies who are from extramural units, they have to be a bit careful here. The second thing is the cot pH, as this forest clause shows that your cot pH at admission is going to be less than 7, which signifies that the baby has had a significant perinatal insult. Then cooling works. Your death before hospital discharge becomes significant, and this baby is, I mean, likely to benefit from cooling. But if your cot pH at admission is going to be more than 7, 7.1, 7.2, which could be likely because that this insult has happened a bit earlier than the immediate intrapartum period, or it could be some other reason for this presentation, like an IUGR baby, or some other reason could be there. Then cooling does not work well. So having a cot pH less than 7 ensures that cooling works well. And lastly, in admission temperature, the baby is going to have an admission temperature which is hypothermic, that is less than 36, then your cooling does not work well. So that is why this concept of having passive cooling during transport is gone now, because if your admission temperature is going to be less when it comes to the cooling center, then the cooling is unlikely to work. It could be more harmful also. So right now, if you are doing cooling, it is better to receive the baby with normothermia during transport and start cooling after they come to the hospital with no passive cooling. So this is the NNF position statement which was released in 2021, which came after that results of the HELIX trial. So NNF now recommends that cooling should be done only in advanced units who have imaging facilities and EEG facilities where there is good nursing care, either 1-to-1 or 1-to-2, because these babies are likely to be very sick. So they have require very dedicated nursing care, and they should be having facilities for continuous monitoring of these babies to give IV infusions, inotropes, blood products if babies are going to be bleeding. And not only that, they should be having capability of following up these babies in their follow-up clinics and ensure that the babies comes with a normal temperature between more than 36, that is up to 37.4. And NNF also cautions against cooling in these criteria. If there are going to be genetic or congenital abnormalities, baby is going to be severe IUGRs, especially the weight is going to be less than 1.8. The baby is having severe coagulopathy, bleeding from all sides. When we don't cool, preterms, I was telling you earlier, even 35 weeker is not an ideal candidate for cooling because cooling would be harmful in this population. The baby is presenting after 6 hours. The benefits of cooling could be very marginal. So it's not good to have a therapeutic drift here. Stick with the strict criteria which we actually using so far. Cooling in mild encephalopathy, which generally happens because these babies make a MACBET requirement in the first 6 hours of life. But mild encephalopathy, even though studies are showing that cooling does not work in this scenario, people do cool, but it's a very controversial area. More studies are invited in this area. And last thing is cooling for postnatal hypoxia, like a baby had a hypoglycemia, cardiac arrest for some other scenario, then comes to you with HIE. So this is called the sudden unexpected postnatal collapse, the sub-C category. So cooling has been tried in some case series in these babies also. It has been found to be helpful, but we don't have good randomized control trials. So these are the devices which we use for cooling. The common ones being used are their automated ones like your Tecotherm, Blanket Roll, Criticule, and now we have Make in India devices like your Neotherm and Brahmi. And so we are gradually moving away from your manual devices. When it comes to the manual devices, the most important one is your PCM mattresses, otherwise called the phase changing material mattresses, which goes under the trade name of Iracredib. So imaging is mandatory because earlier the thinking was imaging need not be tried, but right now since imaging has a direct link with association of your parental insult with your HIE and also later developmental outcomes. So imaging is mandatory in these babies. So this is when we try to do the imaging because these are the four modalities which need to be there in your MRI, your MRS, your DWI, T1 and T2, just to capture everything. I think the ideal time to cool will be ideal time to do the MRI will be between 4 and 7 days, just at the end of first week of life after you finish your cooling. And these are the MRI patterns which are there again beyond the scope of this talk. People have to remember the peripheral pattern or the watershed pattern where basically your watershed areas are being involved, the perilorlandic area and your hippocampal area, and your central pattern otherwise called the BGT pattern. This is the basal ganglion being involved here, or it could have a global pattern where the entire brain is getting involved here. And there are certain scoring systems, and the common ones being followed is the NICHT NRN scoring system, and which is having a good prognostic value also. So fellows who are interested, they can go, just note down this NICHT NRN scoring system, go and read about it. And the only thing about these scoring systems is the higher the score, the worse off it is going to be for your further neurodevelopmental outcomes. And this is the last slide where added therapeutic interventions, the role of them. This way added therapeutic interventions are being trialed is in spite of therapeutic hypothermia, and if it's going to be in the moderate encephalopathy category, 40% of the babies still might land up with abnormal neurodevelopmental outcomes. And if it's going to be a severe encephalopathy category, 60 to 70% of the babies could still land up with abnormal outcomes. So whether we could bring down this abnormality, people have looked at some hypothermia plus interventions. The most promising among them was the intervention which helped in the repair process called erythropoietin use. So the HEAL trial is a very big trial of around 500 infants, and where people have looked at hypothermia plus erythropoietin versus hypothermia alone. Unfortunately, that trial did not show any difference in the combined outcome of death and neurodevelopmental impairment. And more importantly, erythropoietin group had more complications like your thrombotic complications, and other adverse effects were more in the erythropoietin group also. So right now, even though erythropoietin is the most studied agent as the hypothermia plus agent, but this is also going slowly. I mean, with the recent trials which are coming up, I don't think our practice of hypothermia alone is going to change. And what might change it in the future is the stem cells, because stem cells, you know that these cells have a particular affinity to home in on the damaged areas. And if your brain is going to get damaged, your cord blood cells could home in there and help in the repair process. So these are all exciting new interventions. But at this point of time, whatever limited studies we have, we don't have much evidence for them. All remain investigational. And last slide is going to be on prognostication, which is very important as a thing. So immediately after birth, I mean, people tend to ask us, how do we prognosticate? During the cooling phase, people tend to ask us how to prognosticate. And once the baby has finished the cooling and baby is getting stabilized and planning for discharge home, these are the different points where people or the parents tend to ask us how to prognosticate. So it's going to be immediately in the first 6 hours of life. Your UPGAR score could have some role here. Your categorization as mild, moderate, or severe encephalopathy could have a role here. And if you have access to EEG during hypothermia, abnormal EEG or AEG also could have a role here. All this could say that the neurodevelopmental outcomes is likely to be abnormal. But more than that, during the cooling phase, if you have an option to do an AEG, your sleep wake cycle, the return of the sleep wake cycle is telling you that this baby has made a significant recovery. And non-return says that this baby could be having an abnormal outcome. And a lot of units don't go have access to EEG or AEG or EEG. But if you have an access to ultrasound, as is likely to be there in most units across India, you can do the resistor index, and this RI is going to be less than 0.55 between the day 2 of life. Then that baby could be having an abnormal neurodevelopmental outcome. And after discharge, I mean, after cooling phase, prior to discharge, what determines abnormal neurodevelopmental outcome is you are going to be your staging and some other signs like the baby is having tone abnormalities, fisted hands. I mean, there's some suck swallow incoordination with being on tube feeds. I mean, even after at the time of discharge, all this could tell you that this baby are refractory seizures. This baby could be having an abnormal neurodevelopmental outcome. And of course, we talked about the MRI. MRI, especially with the scoring, NICHD, NRN scoring, we could tell about the abnormal neurodevelopmental outcomes. So just as a glance, this will tell you if you have an EEG, better to go with the EEG. Look at the normalization of the EEG in the first 48 hours of life, the sleep wake cycle, and improvement in encephalopathy. So all this will tell you that this baby is likely to have a better outcome rather than a worse outcome. So I already talked about that medical legal issues here. Use the right terminology. If you are seeing the baby at birth, it is better to put a diagnosis as encephalopathy. And after having evaluated the baby with other things, the time of discharge to mention this term as HIE, but does not prevent us from actually considering therapeutic hypothermia. And also, I was talking to you about this, ACOG criteria. So to actually ensure that we actually link the significant intrapartum to peripartum events with our HIE, it is better to document the UPGAR scores, and the baby is going to get outborn. Call up the hospital which referred the baby to you and ask about the UPGARs, because UPGARs are mostly given in retrospect. So with the condition of the baby and after birth and what happened, the restoration measures, when you can actually get a better UPGAR score or give a better UPGAR score on what is documented in the case sheet. And if there is any doubt, go for MRI, because MRI not only tells you that this insult is a significant parental hypoxic insult, it gives you other information also like prognosis. And if you have a doubt, maybe it doesn't have a significant hypoxic event, subsequently presenting with encephalopathy, other etiologies can also ruled up with if you have an MRI in hand. And documentation of everything is vital. And always ask your obstetrician whether this, especially if it's going to be an inborn baby, whether there was some fetal monitoring done, look at the CTG trace, see whether there was any very significant CTG abnormalities before you actually link that particular encephalopathy with the significant intrapartum and perinatal event. So these are my take-home messages. So perinatal hypoxia is a very, it's almost, it's an inevitable thing in spite of whatever preventive measures we choose. So neuro exam is for assessment of perinatal hypoxia, and encephalopathy is mandatory. So EEG, it is better that it is there, but it is not there also. We don't have to break our heads. So therapeutic hypothermia is the standard of care across the globe, but in low middle income countries, especially after the Helix trial, it becomes more context specific, especially because we have to choose the babies which could actually benefit, like having a good, being normothermic at admission, we having a COT pH less than 7, are being born inborn, which could actually link that perinatal intrapartum event with the encephalopathy the baby is having. And when it comes to care, still supportive care, counseling, documentation, and follow-up is needed to establish that is going to be an established management option. So thank you all for your patient listening. I just overshot by 10 minutes. I apologize for that. So if there are any questions to be taken, I can take it up.
Thank you so much, Dr. Girdhar, sir. And I think it was a fruitful session starting from, I think, definition and the signs and symptom and the treatment. And I think, and I will ask any question from the delegates. You can unmute and directly you can ask to sir. And we do have our advisor, senior faculty, Sheila madam. I think if anything from her also we would like to hear.
Sure, sir.
Gidhar, I had one question because many times when residents are managing, especially in a public sector, means government units, and invariably as a compensatory CO2 washout has been occurring in all these asphyxiated babies. What could be the measures which could be taken very early to prevent this CO2 washout? Because all of us know we don't want hypocarbia to occur. Because the first gas he sends me on WhatsApp, I find there is very significant CO2 washout
Yes,
because they
ma'am. I
end
think
up overventilating also.
yeah, I think it's more or less it becomes inevitable at times because even if the baby becomes, we ventilate this child for the initial apneic episode the baby is having. Subsequently, the baby starts breathing also, and they become more tachypneic and they wash out the CO2, provided that the lungs are clear. And it becomes very, even in kind of keeping low settings also, it becomes very difficult to avoid. But what one more thing about CO2, especially since residents are there, we know that when the baby is actually undergoing cooling, your CO2 levels, production of CO2, the body itself will start coming down because of the low basal
Metabolic rate.
metabolic rate.
Metabolic rate, yes.
As your temperature drops, there will be a commensurate drop in your PCO2 also, which is likely to be there. So I think people have looked at some correction factors like zero point 0.8. Suppose if your actual PCO2 that is shown up on the thing is around, it's 30 is getting shown up, you have to multiply it by zero point 0.8. So that will be your correction factor. So that you have to add it to 30 to take it to the next one, actual CO2. So that is for a baby who's having hypothermia. But a lot of times, otherwise, only thing is we have to be very careful about your ventilation settings. We are basically ventilating a normal lung for a baby who's having a very deranged respiratory drive. So go with settings of 30, even 20 at times could be okay. Volume guarantee, whether sitting with volume targets the lower end, like your 4.5 to 4 ml per kg, and placing a blood gas, and so that even if we have one PCO2s on the lower end, so we make some changes to the ventilator, and for having a follow-up gas which says that the PCO2 is slightly corrected, and all these things will go a long way to avoiding this hyperventilation and hypocarbia that actually happens during the management of babies with HIE. Plus or minus therapeutic hypothermia, because therapeutic hypothermia could worsen your hypocarbia also.
Now, again, therapeutic hypothermia is not so much available even in your outborn babies, but
Yes, ma'am.
usually you end up, because nowadays we've been advocating definitely, still we do get that where people have given soda bicarb because when they see a low pH and a low bicarb with this,
Yes, ma'am.
probably
You're perfectly right, ma'am. I think practice variation is there because units tend to treat these babies, with their own ways. Soda bicarb, right now we know that it can giving a bicarb to the baby who's already having acidosis could even, respiratory acidosis could even worsen the intracellular acidosis. So
true.
this baby's cellular metabolism could get deranged with soda bicarb. So people generally don't advise until the pH is quite low. There is a very severe metabolic acidosis. I mean, in such a range that your anadrops are not working because of your severe acidosis being there. The
Acidosis.
time you generally give. So short of that, hypocarbia, even though we try take all measures to avoid hypocarbia, inevitably it creeps in there. One or two records we see in our unit also. I mean, with your CO2 levels less than 35. And
Yeah, it's very, very common to see. I mean, around 30s and all. Like, if you give them a target that it's okay to be 40, but only thing is, hopefully, they. And so, again, at that frequently, they are not monitored. So, how long does it get corrected?
yes, ma'am. Totally.
Remains a dilemma.
Yeah, it is the dilemma. You're totally right, ma'am. I think people have not looked at this particular aspect in our hypothermia trials. Basically, people looked at pH. People looked at your, other things like your outbound, inbound status, your admission temperature. But I think in hospital, people, what are the CO2 levels, analyzing what has happened to the CO2 levels during the care, and subsequently looking at outcomes like your death or disability. This particular thing has not been seen in any of these trials. Even the helix trial, even though there is a documentation on the PSCO levels, they are not stratified and analyzed based on that. I think this will be when we're going to see one more big study from our own setups of therapeutic hypothermia. I think this analysis also has to come in so that the impact of this one on your death or disability could be actually more clarified, man.
True, true. Because now most of the units are doing ABGs. It is
Yes, ma'am.
available. So, I think our next phase, we should correlate it more with our
Yes, ma'am.
hypocarbia levels. True.
Perfectly right, ma'am. Yeah, thank you,
Yeah,
ma'am.
otherwise very well presented, guys.
Thank
Probably
you,
in
ma'am. Thanks.
short time you have given overview of all the things. And this, as far as cord milking, probably yes, because overall we all have now realized that delayed cord clamping has been helping us as
Yes,
far as the neonatal survival as well as long term is concerned. Because milking till now we have been avoiding, but now this new data coming up telling us that milking is better. I think wherever they are going for immediate cord clamping, or as the new trials coming up of doing it on mothers. I mean, you do resuscitation by the side of the mother
yes,
and
ma'am.
don't. Both the things could
And
make a
I
difference.
think there's a new terminology also coming, like in the preterm also they are giving a long cord to give a eye means intake cord, giving a 50 centimeter of the cord, so you can, once you resuscitate, yeah, once baby survives, you can pour their blood properly to the red preterm babies. Even also in the term baby, people are used to do that one, because in 28 weeker, I think less than 28, we are not allowing to do the milking, but
Yeah,
they
yeah,
can
yes.
give the intact code. So that's a new data is showing a promising outcome. And if we talk about the preterms baby also, yeah,
Yeah,
I
yeah.
think our biggest challenge would be the safe transport also. Like when we receive the baby from the periphery, we know that how when we visit over there, of course, we can try to manage that one. And the most of time when we reach over there, the baby is already hypothermic. The pH is fluctuating between 6.9 to 7.1. Over ventilation is there, so there's a lots of changing. Even though you reach in time and baby receive the cooling therapy within the 6 hours of the life. What's your own take? Like, for example, if in periphery, I think someone is should we offer the cooling? Like, if they have to offer the cooling because of this controversy, what affect the medical legal? If some one of the pediatrician in periphery not offering the cooling, and we receive the baby after 24 hours, and one pediatrician offering the cooling, and we receive within 6 hours. So what's your take on? Because it is difficult to do the counseling to the parents. When actually you are sitting in the tertiary center, and one person is not offering the cooling, but baby is referred because of the sepsis or hypoxic, respiratory failure, and one person is same city is referring for the cooling. So I don't know what's your take on that one. How you know.
See, actually, prior to 2021, before the reports or results of the Helix trial was published, there was a real
Mm,
difficulty because India, as you know, is setting with various settings are there in India, and center could actually, different, people with different expertise could manage babies like these. And some centers don't have expertise for doing cooling. And even though they say that they're doing cooling, they might use some low-tech devices, and the monitoring might not be that rigid. That could even land up harming these babies. But if we don't tell them that we have cooled these babies, that could be a medical issue also. And as you know, some units, practice of transfer to one other unit for cooling is not that established in India even now. Okay, so that is a problem. But after 2021, I think it has become more easier medico-legally. So we could afford to say that we have not cooled because of the Helix trial having shown that in LMICs it's dangerous. And you could
mm,
say that we have cooled it because my unit is a level a very advanced newborn unit, and I have received this child. I've taken all the measures to ensure that the baby is cooled in the right way, and the monitoring is also very rigid and protocolized. And we have cooled. We have an antecedent of cooling so many babies with good outcomes. So you could get away with doing both. But I think
yeah. So
what we convey to the parents is more important here. I think if the parents, we should still tell them that the only recognized treatment for this sort of a presentation at birth is only cooling. Because we are seeing
cooling,
that
yeah.
other treatments, they're still investigational, and none of these have actually worked in randomized control trials. So cooling is the only thing we have. Even though cooling could be a bit fallacious after this Helix trial, I think most of us still do cool, and only thing is we have to do some quality improvement measures to ensure that if we are an outbound hospital which is transporting across a wide distance, then your transport system has to be in place. It should be so good that they know what to do during this when transport of these child. But earlier, the passive cooling is something that people were doing now. But now, I think cooling them in the transporting them in normal temperature is more important. So have your transport system in place. Once you reach the hospital, you check the blood gas, you stabilize the baby, then you shift the baby with ongoing monitoring and ongoing intervention, not cooling I'm talking about, and ensure that the temperature does not get much deranged. That happens. Whatever is the admission pH which you have had is actually the pH which has been at the point of birth. And it's not anything that has happened after birth. A lot of times, which happens after birth. But I think to have this rigid and protocolized transport system is not going to be easy, but that is what I think as neonatologists, we want to run hospitals. We want to call ourselves level 3A centers. I think we have to start doing that.
Yeah, yeah. Thank you so much. I think anything from the Kunal.
Yeah,
Kunal.
no, excellent talk. Thank you so much, Dr. Girdhar, for accepting our invitation and presenting such a lucid and wonderful talk. It was very simple and easy to understand. It will be there in our YouTube channel also, so definitely everyone else later on also get benefited. So I think if there are no further questions, we can conclude the session now.
Yes,
So
sir. Thank you.
thank you so much. Thank you,
Thank
Vishal,
you so much,
for
sir.
getting the
Thank you.
session.
Thank you,
Thank you,
sir.
Shreya ma'am.
Thank you.
Thank you.
Yeah, thank
Thank
you.
you, ma'am.
Thank you, ClearNet. Yeah, thank you. Rituparna, we can end now.
Much everyone for sharing your valuable insights. So, with all your permission now, we are ending the session over here. And thank you once again for extending us the opportunity to host the session today. Looking forward to host you again soon. Goodbye till then. Take care, everyone.